Start Broadcast button on the GoToWebinar control panel to allow all attendees to hear you. This system will notify you once you begin your broadcast. The broadcast is now starting. All attendees are in listen-only mode.
Hey, good afternoon, everyone. Welcome to the ACO Learning Series. Today we're going to do things a little bit differently. We're doing this via recording. We've had some people say, hey, we don't care if we do it live or recording. We need the recording anyway, but we want it to be shorter. So we're going to make this short, quick. We're going to do some very focused learning, and I want feedback. We need feedback. Tell us if you prefer this method or a live method of educational training, and we will do whatever we need to do to make your needs. We try to be flexible so that we can have very robust ACO here. So housekeeping. This is for educational purposes only. The webinar will be recorded, and obviously is, and you may share this with any other member of your staff that is in our ACO. And anyone who signs up for the webinars, get a copy. So just remember, if you receive a link to sign up for a webinar, please do so. That way you'll always get a copy of the webinar. So we're going to do a quick review here. We're going to focus in on HCC scores. What are they? Why does it matter? And we've had physicians say to us, just tell me what I need to do and I'll do it. Actually, physicians are very good. Clinical staff is very good. If they know what's needed, they can do it. They're smart. These are smart people we're dealing with. They just need to know the direction and what to do and why. So let's go ahead and talk about HCC scores and why they're so important. An HCC score is a hierarchical condition category. Now, that sounds cool, but what does it mean? Medicare says that HCC scores will predict the future healthcare costs for beneficiaries. So it's a risk score that allows Medicare's to understand how sick the population is and adjust payments accordingly to how sick the patients are. Okay, so what does this mean? HCC scores translate into dollars. How does HCC scores or a risk category translate into dollars in Medicare's eyes? So let's go ahead and look at that. All an HCC score is a risk score. How does Medicare know what risk category your patients are in? From ICD-10 codes, from your diagnoses. A diagnosis code tells Medicare a picture of what your patients look like. They help understand a ICD-10 score, a diagnosis helps Medicare understand what your patient looks like. So we have a patient here who's rather robust. He's healthy. Generally, he has high blood pressure. Not unusual. We see a lot of claims going through to Medicare with a patient that comes in the office for high blood pressure. And the claim goes out to Medicare, and we told Medicare the patient has high blood pressure. So we explained to Medicare, this is what our patient looks like. No problem. What's interesting is this patient also has high blood pressure. Looks drastically different than the patient in the previous slide and has multiple comorbidities. This patient has high blood pressure, heart failure, diabetes, COPD, obesity, hyperlipidemia, and chronic kidney disease. So these two patients have one thing in common. They both have high blood pressure. So when we send a claim to Medicare on a claim form and we say this patient has high blood pressure, I-10, we're telling Medicare that these patients are identical. Okay, physicians will push back and will say, wait a minute, I can't upcode if a patient's just coming in for medication. True. But when that patient comes in for a medication adjustment for their high blood pressure, does a physician not take into account all these different comorbidities? Is a physician going to give to a patient the same medication for their blood pressure that has COPD or chronic or kidneys are failing? No. The physician goes through the mental process, whether they write it down or not. This patient has this disease process. This disease process affects this patient's high blood pressure also. So let's just say this patient came in and they had the flu. And they had maybe an underlying, it was moving to a bacterial infection, maybe strep, anything, right? Okay, so the patient comes in. Patient has high blood pressure, has the flu or bronchitis or something. Well, if you just put down patient has high blood pressure and the flu or bronchitis, let's use bronchitis, but you do not, and you give the patient medication, which will normally happen. You know, we don't want that bronchitis to go to pneumonia. But we're thinking about what kind of medications can I give this patient since they have kidney disease, since they have COPD, heart failure, and diabetes. What kind of medicine can I give them that will not interact or cause problems for his other disease processes? All this is going on in the back of the doc's head. So the physician needs to be able to understand how to communicate to Medicare. Here's my patient. Sure, they're coming in for bronchitis. He has high blood pressure, but he also has CHF, diabetes, COPD, hyperlipidemia, chronic kidney disease, obesity. We need to be able to communicate to Medicare. When this patient comes in, these are the type of things we have to think about for the patient. This patient becomes much more complex than the patient on the right, old Popeye the Sailor Man coming in, has a little bit of high blood pressure and has bronchitis. Two different patients, two levels of complexity. Now, why do we care? Because everything in life comes back to value-based medicine today. You're going to be sick of hearing it by the end of the year, but value-based medicine is where we're at. In value-based medicine, we must be able to communicate to Medicare what risk category, what HCC scores our patients have. Medicare macro dollars are given out, are paid out according to risk categories, because it's bundled in the cost element. So how does this all work together? Okay, I do believe, people will tell me, Teresa, okay, I understand. We have to be able to communicate to Medicare that our patients are sick. And I go into physicians' offices all the time, and they tell me how sick their populations are. We're in a rural area. We have a very sick population because people put off going in for preventive care because they didn't have insurance. And as soon as they get Medicare, they come in and they are sick. They have full-blown COPD. They are starting CHF. They may be diabetics, but that's never been treated. Happens every day. Well, in value-based medicine, in the ACO and MACRA, we know we report out on quality. We've already been working hard on quality. Every month, we're getting together with you to start building out your quality program. We know we must do improvement care activities. We do that through the ACO, through this educational series, and building out your EMR. We work in advancing care information through chronic care managers. Ultimately, what we're trying to do is bend the cost curve for Medicare. Remember, when we bend the cost curve for Medicare, we succeed for Medicare. Now, cost also equates to risk scores. So if you have a healthy population, Medicare is going to say, when it comes to your cost, if your population only has high blood pressure and not a bunch of other comorbidities, why are you spending so much? You must not be a good physician. You are not being a good steward of Medicare's dollars. This is how Medicare thinks. Now, yes, you know your patient has all these different comorbidities here. You know your patient has hypertension, CHF, diabetes, COPD, obesity, chronic kidney disease. But does Medicare know? If we haven't told Medicare they have that, they're going to think, oh, your patients are healthy, but you're spending a lot of money. No, you don't get credit for the cost in your MACRA. Is that true? Is it true that your patients are all healthy? Okay, so what I'm trying to get here, I've kind of really taken some extreme cases here, but Medicare only sees us through the eyes of what we tell them. It's not even fair for us to assume that Medicare knows our patients are sick unless we tell them they are. Unless we tell them that our patients have multiple comorbidities, how in the world does Medicare know? Well, Medicare allows us, since we're in the ACO, to see our patients' information. We know what risk scores Medicare knows about. We know the diagnoses. We can see them, that Medicare realizes. So how do we look at that to see if there's any holes? We have an incredibly powerful tool. Our ACO portal, across the top when you log in, there's something called fit analysis. Now we're going to get to some of the nitty-gritty here. In the fit analysis, there is a quick data tool, and it's called beta because we're still working on it right now. It's still being enacted, and it should be enacted in your portal by the end of the week. That's why we're coming out with this today. So by Friday night, Monday morning, should be active for you. Under the fit analysis, there's a quick data tool. So we're going to drill down into that quick data. Here's what it looks like. Within the quick data tool, there's all these different reports. They have filters. There's a little filter up by next to the report name, and you can filter by HCC, and because we're looking for HCC scores, risk scoring. We're going to look at the comparison to the previous year for this particular report. So we're going to go to the HCC comparison to previous year, and then we're going to go over and click on the risk assessment on the little click down, but we're going to use the comparison to previous year because we want to see what is missing from the diagnoses, what Medicare does not know that they knew before. And then we're going to click run. So this report is cool. It has tons of information on it, but we're only going to look at a couple different pieces for right now because remember, we're going to do bite-sized pieces real quick here. So in column Q, we have the HCC changes. The HCC changes, this is actually changes from 16 to 17. The reason why 18 data is not in there, even though we're being loaded 18 data right now from Medicare, the reason why the 18 data is not in there is because if the patient hasn't been seen, it's going to be empty anyway. So we're going to look between 16 and 17. That will tell you where the holes are and where you need to start from. So if you go to column Q and sort from smallest to largest, you can see any negative numbers. We're telling Medicare that in 2016, the patient had a risk score, look at this red one, of 3.321. That's a pretty sick patient. Over 1 is fairly sick. But in 2017, the patient got better. The score went down. And here's the change, the HCC change. So let's see what was removed. In column Q, you can see what was removed from 2016 to 2017. I'm telling you, the data we have is powerful. All this data comes from the assimilation from Medicare, not just your office, but if they went in the hospital, we've got that data in here too, and assesses it in. So if a patient goes to the hospital and the hospital says, yeah, this patient has CHF, great. Do not rely on a hospital or somebody else recording what's wrong with your patient. We're trying to keep patients out of the hospital. Save some money. So look at this here. We're going to focus in on, we're going to take a laser view of those changes. Anything in the negative, that means that the patient got better. Now, it could be true. So we'll look at this particular patient, and poor Mr. Smith, he no longer has prostate cancer or tumors. Mr. Smith must be thin. Well, if he did have cancer, he might be. But Mr. Smith may be thin now because he's not morbidly obese anymore because it was removed. Miraculously, Mr. Smith was cured. All he has left is high blood pressure. All his other comorbidities went away, it looks like. Is that true? Mr. Smith no longer has prostate cancer. Mr. Smith no longer has disorders of immunity. Mr. Smith no longer is no longer morbidly obese or endocrine disorders. That's interesting. Is this true? It happens. I mean, in some cases, yes, a patient's really sick one year and next year they're better. They do get better. So Medicare would say, hey, great, you should be spending less money on this patient because they're better. Is that the case? So in this report that you can run, start to filter out looking at your patients. Which patients' scores are you telling Medicare this patient got better, and did they really? So this is the information you would give doctor. Doctor, this is Mr. Smith. We took Mr. Smith the question would be, does Mr. Smith have these disorders any longer? Yes or no, doctor? If they do, we need to make sure this patient's on chronic care management and we capture these disorders the next time they're in the office. In most of the EMRs, we can make notes. In most EMRs, we can even click off the type of comorbidities the patient has. And so on the next bill, when the patient comes in the next time, we can go ahead and make sure that Medicare understands what our patient looks like. So that's it in a nutshell. Real quick recap what we're going to do. First of all, if you need anything, reach out, please. Let us know if you like these little mini series better than the longer ones. We're happy to do them like this. So how do we do this? We're going to go to Fit Analysis. We're going to go to Quick Data Tools. Within the Quick Data Tools, we're going to do our drop downs or find the report that we want. This particular report is going to be an HCC score, so I'm going to put that in my filter, click Filter. I then click onto the left-hand side under Risk Assessment, Comparison to Previous Year. I'm going to click that, and you'll get a drop down for your report. Use the year 2017, run your report. Filter your data on Q for reverse order, so you can see with your ones you're upside down on. In other words, patients that got better, and have those patients really gotten better? That's the question. Review this with your physicians. To the left, you'll see which physician they're assigned to, your practice. So you'll be able to really, really start to target any type of problems that are going on with your HCC scoring. All right, everybody, thank you for your time. I hope this works well for you. If not, we can do live. Just communicate with us. We can work with whatever you need, whatever fits your office needs the best. Take care. Have a great day.